Hi, everyone, and welcome to another episode of Dr. Gilbert Host. Today, we're going to be discussing a very important topic that can dramatically affect people's quality of life, and that is vision changes associated with Parkinson's disease. You may not even be aware that vision can be affected by Parkinson's disease, so we're glad that you're here, and you will learn from our expert. So our expert today is Dr. Janet Rucker, who is a neuro-ophthalmologist who has expertise on this topic. So to start us, Dr. Rucker will give us a brief introduction, and then we will be answering your questions. So get those questions ready, and we will be answering them live after Dr. Rucker's presentation. So it's now my pleasure to introduce you to Dr. Rucker. Dr. Rucker is the Bernard A. and Charlotte Marden Professor of Neurology and Ophthalmology at New York University School of Medicine, where she also serves as the Division Chief and the Fellowship Director of Neuro-ophthalmology. After medical school at St. Louis University, she completed her neurology residency and her fellowship in neuro-ophthalmology at Emory University in Atlanta. And currently, her primary research interest is abnormal eye movements in neurologic disease. Welcome, Dr. Rucker.
Thank you so much. It's a pleasure to be with you. I thank you, Dr. Gilbert, for the invitation today, and hello to everyone out there. I hope that you'll find today's session very helpful. It's a topic that's probably not talked about a whole lot, and I think that we have some interesting things to learn together and hopefully help you with your vision if you're having any experiences that perhaps your ophthalmologist hasn't been able to solve yet. So I'll go ahead and start with my slides, and I look forward to hearing all of your questions. So don't be shy. Please send in your questions, and Dr. Gilbert and I will have a great discussion and try to answer them all after the talk. I have no financial disclosures or conflicts of interest. So the scope of the issue, this is a good place to start. There's been studies looking at the prevalence or the frequency of visual symptomatology in patients with Parkinson's disease. And shockingly, the number is almost 80% of patients with Parkinson's disease have at least one visual symptom. Now, these visual symptoms may or may not be related to the Parkinson's disease, but they frequently will include blurred vision. Difficulty reading is a very common one, sometimes double vision. There's two different kinds of double vision. There can be double vision that if you cover one eye, you still see double vision. And then there can also be double vision that goes away when you cover one eye. So it's only present with both eyes open. And those can be from very different things, which I'll come back to a little bit later. Light sensitivity is another one. And unusual things such as misjudging objects or how far away something is from you. And then visual illusions. The word illusion is a misperception. Or hallucinations. That word is specifically seeing something present that is not really truly present. And some unusual things such as having a sense that something is present in the room or that something is passing by you when there's really nothing there. And then more complex hallucinations. Common with Parkinson's disease in the hallucination area would be seeing things like small children or even animals or pets that aren't really present in the room. So here's the roadmap to what we're going to cover in the talk part of the session. How do we actually see? We don't just see with our eyes, we ultimately see with the back of our brain. So we're going to talk a little bit about that. We're going to very briefly touch on some things that have been found in the research arena that aren't necessarily clinically relevant, meaning they might not be detectable with routine eye doctor testing, and we may not have specific treatment for them, but there's been a lot of research in the visual system in Parkinson's disease. And what we'll really focus on, though, is those things that are common that we can find on examination and that actually have a very practical treatment that you can pursue for them. And then we'll summarize with some simple solutions and final take-home points. So first, how do we see? I love the analogy of an old school camera with its camera film that you put in the camera, and then you have to take out that film and take it for processing. So the eye itself is the camera. It's collecting the visual information from the world. The camera film is the retina lining the back of the eyeball where all the visual imagery falls. And then from the retina, it goes back through vision nerves or optic nerves, and then all the way back through visual pathways in the brain. And the final stop is going to be that back of the brain, the occipital lobes, the vision part of the brain. And that's really the dark room where the vision finally gets processed. So here's a cross section, kind of a halfway cut through an eyeball. The front of the eyeball up top where the white curvature is, that's the cornea. And then right behind that, we have the lens of the eye where people get cataracts from just clouding of that lens over time. And then the orange is the vitreous in the eye. It's a fluid that gives the eye its shape and provides a lot of nutrients to the eye. In the orange, the lighter colored orange, almost yellow lining, that very little bit of lining around the back on the inside of the eye, that's the retina. And then all that visual information is coming off at the very bottom through the optic nerve to carry it back to the brain. And when we look in the eye, as your ophthalmologist might use a couple of different tools to look in the back of your eye. This handheld ophthalmoscope is one way that we look. And you can just kind of follow the arrows along the bottom. So first we just see the normal eyeball, and then we get this bright red kind of reflex where the pupil is, and then we keep coming closer to you, and we start to see blood vessels and the retina in the back of the eye, and we come in and finally we get this nice beautiful view in the upper right hand corner of what the back of the eyeball looks like with the optic nerve, the retina, and blood vessels back there. So we're actually looking at a piece of the brain, the optic nerve, when we look in the back of the eye. And here you just see another cross section that's kind of highlighting a piece of that red lining. Now that red lining being the retina, showing you all the different layers of the retina, which is what is processing the visual information and coming together as the optic nerve to carry it to the brain. So the big picture is that the visual information comes into the eyes, and then it goes all the way back through the brain, and different parts of the brain are responsible for different aspects of vision. So there's a piece of the brain that's responsible for seeing color. There's a piece of the vision that's responsible for detecting motion. So you can start to come to the conclusion that visual symptoms could definitely come from the brain, and they might be related to a specific thing like motion, yet everything else seems to be normal. So it can kind of pick and choose different brain areas that might become affected. And then on top of the visual system, we have our eye movements, and we move our eye movements around we move our eyes around in order to put a very special piece of our retina, the macula, right on anything we're looking at, because that's the part of the eye that we see the best with. So when we look at something, we're putting our macula right on it. And in this photograph, black and white photograph in the center, if you look at the individual right in the middle of the photograph, nice and sharp, clear visual appearance, but you'll notice that everything fades off to the sides because we don't have very good peripheral vision. We kind of look around to get things into sharp view. And then you can see in the right-hand side, if one eye is not moving correctly, if it's displaced outwards, inwards, upwards, downwards, then that image coming into the eye is going to fall on two different spots on the retina between the two eyes, and that's when the patient can get double vision. And we have lots of different ways that we move our eyes to make this happen. We have kind of a busy visual scene to the left surrounded by the green, and we have to make very fast movements around that scene, maybe to find something in it. In the middle, we have a face, and the way we recognize a face is by making these fast eye movements between different features of the face that allow us to recognize it. We have to be able to maintain sharp vision when we're walking and moving our head and body. And then we might slowly follow something moving like a bird in the sky. So we have a lot of different kinds of eye movements that do these different. And then this one is most pertinent to Parkinson's disease. And this is when we read, we converge our eyes. So if you look at the little black and white cartoon up there showing the eyes kind of would be turned in towards the nose, that's called convergence. And we need that movement. We have to be able to bring our eyes together to be able to do work up close, like reading. And you can see in the bottom picture, if the eyes are just pointing straight ahead and not converging well, they're going to be looking at two different points on that page and maybe giving some double vision. So this weakness of this convergence is quite common in Parkinson's disease. So in the research arena, it has been shown that we do have dopamine cells in our retina, and that there is alpha-synuclein, the main pathology in Parkinson's disease, in the retina as well. So if the right testing is done, and this is very what I call subclinical, we're not going to find this in the regular eye doctor office, but if we do very specialized color vision testing or contrast vision testing, like the bottom disappearing eye chart in research space, we might be able to find a little bit of a deficit, but these things are not things that your eye doctor is typically looking for. So moving on to the common abnormalities that we can do something about, it's not at all an uncommon picture in my clinic for a patient to come say, I have Parkinson's disease. I'm not seeing well. I'm really unhappy with my vision. I saw my eye doctor. They said everything was good, but I'm not happy. And that's who's going to come to me. And we're going to look for, in particular, convergence insufficiency or convergence weakness. So this is present in 40 to 50% of patients with Parkinson's disease, but it's not symptomatic. It's not causing trouble in all of those patients. But patients who are struggling with it will notice that they're developing some double vision when they try to read, but it might also not be that obvious. It might be that things are blurry with reading, or it might be that when you try to read, you can only read for 5 minutes and then everything is blurry, so you can't sustain reading any longer. And this is rarely dopamine responsive, so your Parkinson's medications are only in a very rare instance going to be something that help this. What we do for it, we can do eye movement exercises, send patient for vision therapy, where they do exercises to work on that convergence movement. A lot of times with Parkinson's, though, the convergence problem is so symptomatic, and it might not be a quick enough fix to go for vision therapy, or it may not work. So I'll usually put the patient straight into some special reading glasses that have prisms in them. And down on the bottom, you see an example of prism in front of the eye. Prisms just bend the light. They bend the angle that an image enters an eye. So what I tell patients is the prism glasses for reading, they just take the work off the eyes and put it into the glasses. And those can be very helpful for patients with Parkinson's who are struggling with convergence problems. So to wrap up, just some very simple points and take-home points, and then we'll answer all of your questions and have a great discussion together. Patients with Parkinson's may or may not tolerate bifocals or progressive lenses. Now, it can be a hassle to have more than one pair of glasses, one for reading and one for far away. But if you are not happy and the only issue left to go after is the fact that you're in a single lens for everything, you might try separate reading and separate distance glasses to see if that can be helpful. Just like the body movements become slow with Parkinson's disease, so do the eyelid movements, and blinking is often reduced, which leads to dry eyes. They may not be recognized as dry, but they might be causing blurry vision. So I'll tell patients just to use teardrops frequently. You can't hurt yourself with just natural teardrops, and lubricate the eyes often. And all patients over the age of 50 or 55 should see an ophthalmologist occasionally to make sure that vision in good preventative vision care is being done, that there's nothing else wrong. So I think I'll save this in terms of the differences between eye doctors, but Dr. Gilbert, let's be sure to go back and spend some time on what kind of eye doctors are there and when should I see which type. So one size does not fit all, different glasses, some people need tears, and 20/20 is not everything. So even if your eye doctor tells you you're 20/20, all is well, if you're not happy with your vision, then be persistent. Find another specialist. Look for these issues that I've described because they can make all the difference in the world to your visual happiness. And I think that's it for the slides. And I'll thank you very much for your attention in this little talk. And I look forward to answering your questions.
Fantastic. Thank you so much for that introduction and all that great information. As you were giving your presentation, the questions were coming in fast and furious. We have many, many questions so far. So I'm going to apologize ahead of time if we don't cover everything, but I'll try to group questions so we get a lot of the questions answered. So you had mentioned in your introduction that there's two types of double vision, with both eyes and with one eye. Could you elaborate on the double vision with one eye?
Absolutely.
Oh, yeah.
And this can be a little tricky for a patient to sort out, for an individual to sort out themselves, but it's the first thing that an eye doctor is going to do when you tell them you have double vision. They're going to ask what happens when you cover an eye. So you may be able to answer that question better if you check it at home, and then you can tell your eye doctor. Generally, what the rule is let's say I have double vision. And if you tell me to cover one eye and now I see single, and I cover the other eye and now I see single, that double is only there with both eyes open. That's due to a misalignment of the eyes. So with Parkinson's disease, the most common one would be convergence weakness. But there are many, many types of double vision that don't relate to Parkinson's. So we also never want to assume that the vision problem is from Parkinson's. We need to keep an open mind to all the causes. Now, the other kind of double vision, if I cover one eye and I still have double vision, that is for your regular eye doctor. That's going to be, maybe you need a glasses adjustment, maybe your eye is dry, maybe you have a cataract that's giving you a little double vision in just one eye at a time.
Excellent. Thank you. So we have a question from Angie. So it sounds like Angie probably has convergence insufficiency, has been given prisms, but has been told or feels that her prisms are maxed out. What are the options at that point?
So when we first select a prism size for the glasses, it is based on partly you in the eye doctor's office, but also on the measurements that we've taken during exam. So prism glasses are not, we give you this prism and it will fix everything. It may need adjustment. It may just need adjustment once. It may need adjustments 100 times. When a patient, it's pretty rare for a patient to max out from the prisms, but if someone is being told that and they really cannot converge the eyes at all and the prism is just too big and it's not helping, the best solution to that is to occlude one eye and then to just read with one eye at a time. Some patients get an opaque contact lens if they're big readers and they want to be able to just be hands-free, or some patients get optical shops have a way that they can occlude one lens of your glasses in a kind of cosmetically appealing way. It may be a pair of reading glasses, and then you just read with one eye if it's truly been maxed out.
Fantastic. That is a great solution. Thank you. We have a question from Scott and Barbara. They both asked the same question. Losing night vision, especially when driving. Doctor thinks it's cataracts, but could this possibly be related to Parkinson's disease?
I think probably not related to Parkinson's disease. I think that is mostly related to what I will call contrast vision. So seeing kind of high contrast would be seeing black letters on a white page. There's a lot of contrast there. It's very easy to see that. But for example, low contrast might be if you have dim, like maybe light gray letters on a white page, that's going to be a lot harder to see. And so some of night driving can be loss of contrast vision, but that commonly happens with cataracts. And it does happen, I think, a little bit with Parkinson's disease from the effects on the retina, but not in a clinically significant way, not in a way that the patient's going to notice. And so also with cataracts, there tends to be a lot of glare with driving at night that can be very limiting, headlights coming towards, and you just see a lot of glare that kind of blinds you. That kind of thing is almost always going to be cataracts, and going to be something that's fixable with cataract surgery.
And unmute myself. So the next question is from Robin, which is, my eyelids won't open on many mornings when I wake up. Could that be Parkinson's?
So that's a tricky one because there's a couple of different things that could cause that. When you say that it's specifically when you wake up in the mornings, that leads me a little bit more towards the eye than to Parkinson's. Our eyes get a little bit sometimes crusty. We say sleep in the eyes. There can be dryness in the mornings when we wake up, or a little bit of inflammation around the eyes. So you certainly would want to check with your eye doctor and see if there's any dysfunction of the glands around the eye, or if you're having issues with dry eyes. There is a reason why eyelids can be difficult to open with Parkinson's disease, and the name of that is eyelid opening apraxia. The word apraxia is a medical term that basically, with reference, it doesn't specifically refer to eyelids, but I'll use our eyelid as our example. If the apraxia refers to the fact that the eyelid muscle is fine, it's fully capable of opening, but the apraxia means that the commands from the brain that are trying to tell it to open aren't getting through to the muscle. And that can happen kind of in waves, sometimes off and on. Sometimes it can be a more persistent problem. If it really is something that is a problematic issue and keeping a patient from seeing well because they can't keep their eyes open, that's when we would turn to some treatments for it, which might be some injection of botulinum toxin or Botox around the eyes. But if it's just happening in the mornings and not too, bothersome, and it resolves quickly, nothing needs to be done about it. And it's certainly not anything dangerous.
Thank you so much. Okay, Mary Lou asked about blepharospasm. So can you talk about how apraxia of eyelid opening and blepharospasm may or may not be related, and how to treat blepharospasm?
Absolutely. What a perfect segue to this question from the last one. So we introduced eyelid opening apraxia. So that would be, if I have my eyelids closed and you're telling me to open my eyelids, you may see my forehead muscles activating, but my eyes aren't opening. That would be kind of classic for eyelid opening apraxia. The signals just aren't getting through. There's a continuum from eyelid opening apraxia to blepharospasm. Blepharospasm, bleph is the eyelid, and spasm is just like it sounds, a muscle spasm. So with blepharospasm, you actually kind of have some forced closure of the eyelids and like excess blinking that's a little bit more forceful than normal blinking, kind of like I'm doing right now. And so some patients, especially with Parkinson's disease, there's a continuum between eyelid opening apraxia and blepharospasm. Some patients have features of both. Some just have one or the other. They both, if they're mild, are sometimes not too bothersome. But if they're more severe and persistent, they can be very bothersome. And the treatment for both of them is the botulinum toxin as the first line of treatment, because it usually works very well for that.
Thank you so much. So we have some amazing questions. We have a great question from Harry, which is, how would you differentiate between double vision and depth perception issues? So, for example, Harry mentions that he has difficulty trimming the bushes. He might miss a limb. So how does depth perception weigh in on these issues?
This is a really amazing and advanced question, something one of my trainees might ask me and we would sit down and have a chat about. So, first I want to say that you cannot blame depth perception issues for far away things like missing a curb or when you're walking down the street on a convergence weakness problem. Bear in mind that the convergence insufficiency is only going to be up close. If you're real close to those bushes, it might be playing a role. But if you're more than, say, about a foot and a half away from something, it's probably not going to be convergence insufficiency. It could be due, if you're having depth perception issues up close to you, definitely most likely convergence weakness. If you're having depth perception issues that are farther away, and that is something that I do commonly hear from my patients, there can be many causes for that. There could be a cataract in one eye. There could be a need for glasses in one eye and not the other. If the two eyes are somehow seeing differently, that's going to throw off your depth perception. If the sharpness of vision is not good enough because your eyes are very dry, that could throw it off. If there is a misalignment of the eyes that maybe isn't related to Parkinson's disease, maybe you have a little bit of a weak muscle or nerve from some other cause that requires a diagnostic workup, that is worth getting checked out. So and then there's also, as I mentioned in the talk, specific brain regions responsible for specific things. And there is brain region that's responsible for depth perception. And so that might warrant talking to your movement disorders neurologist and saying, if the eye doctors didn't find anything and nobody, maybe hopefully you could see a neuro-ophthalmologist, didn't find anything, then you might talk to your movement doctor about maybe pursuing what's called neuropsychological testing or neurocognitive testing, because the doctors who do that type of testing have the ability to kind of measure the brain functions of vision a lot better actually than the eye doctors do. So that's a very layered answer to the question, but the take-home point is that there could be many different causes for that. So you need some good doctors to tease apart what's causing that for you.
Great, thank you so much. Another great question, this one from Alona. Can DBS surgery cause vision issues? Since DBS leads may interact with some visual areas. So
I love this question. So I think we have some vision researchers out there in the audience. So this is a great question. The reality to the question is that I think it's uncommon, at least from the standpoint of being something that's going to either fix or create vision problems. So take-home point is it's not common. But if you look at the published medical literature on this question, you are exactly right that DBS, deep brain stimulation, the placement of the leads is very near to centers that control specific eye movements. And so if you look at the research studies on this question, there are studies that show abnormalities of eye movements after from the lead stimulation, and then there's studies that show some improvement in certain eye movements. So it's kind of a mixed bag in the literature, with some things looking a little better, some things looking a little worse. But these eye movements are eye movement abnormalities that are very subtle and detected on research examinations or maybe even eye recordings that are not going to be eye movements that are actually causing visual symptoms for the patient.
Great, thank you. So you talked a little bit about dry eyes and that being an issue in Parkinson's disease. So we did have a question about if somebody has very bad dry eyes, what are some other options besides natural tears that you can suggest? Yeah. And we also had a question about the opposite, where eyes are tearing too much. Could that be related to Parkinson's, and how do you control that?
Excellent. So they both are due to dry eyes. So I'll answer the second question first because it's a very simple answer. If your eyes are watering or tearing a lot, that is a very classic signature of dry eyes. The eyes are doing their best to produce as many tears as they can to lubricate the eyes, but it's just not working. So the eye is tearing a lot, and that is almost always due to dry eyes. So the first question, I think this is a good moment for me to step in with the different kinds of eye doctors. I can answer that question, but I'd like to preface in terms of what are the treatments for severe dry eyes by letting you know that I am not an ophthalmologist. I am a neurologist, a brain specialist, just like Dr. Gilbert and just like your movement disorders neurologist. But my area is the vision system in the brain and eye movements. Now, neuro-ophthalmology as a field is a field where we do a year of training once we complete the rest of our medical training, kind of our final year before going into practice. And people come into the field either from the neurology training side or the ophthalmology training side. The reality for you as a patient is a neuro-ophthalmologist is a neuro-ophthalmologist. Doesn't matter to you if it's someone who came from neurology or ophthalmology. They're all going to know and be familiar with these issues in Parkinson's disease. So neuro-ophthalmology, we are the ones who would mostly deal with depth perception issues, hallucinations, perhaps in concert with your movement disorders doctor, certainly convergence insufficiency, certainly any other kind of eye movement problems. Now, your regular ophthalmologist is someone for good preventative health care for dry eye treatment. And beyond the comprehensive ophthalmologist, we also would have a specialist on the surface of the eye, which would be a cornea specialist. So the first place to begin, if you have severe dry eye and your comprehensive eye doctor, your regular ophthalmologist or optometrist even, hasn't been able to help you with that, you should seek out a cornea specialist. They are the surface of the eye and the dry eye experts. So before probably a decade ago, there wasn't a whole lot on offer other than natural tears for patients with severe dry eye, but there are a lot of prescription options now. Now, I have no financial interest in these medicines. I don't know their generic names, but things like Restasis or Xiidra, there's a nasal spray that can help with dry eyes now. So the researchers have become aware how big of a problem this is, not just for patients with Parkinson's, but many patients over a certain age, usually starting in the 50s. And so there's a lot of great prescription treatments available now. If dry eyes are extremely severe, the eye doctor sometimes will insert what's called a punctal plug. They'll basically plug your tear duct, block your tear duct so that any tears that are produced stay in the eye rather than drain out of the eye. So those are important things to think about for severe dry eyes.
Fantastic. Thank you. That was extremely helpful. I want to connect what you just talked about with a question from Fred, who asked a little while ago, and just to piggyback on your discussion of the various ophthalmologists. So you say that if you are evaluated by an ophthalmologist and you're not happy with your vision, you have to be persistent. What would be the next step in terms of who to see?
So a good place to start is always with your ophthalmologist. Now, optometrists are excellent also. Some people have their eyes followed by an optometrist. So let me explain the difference between an optometrist and an ophthalmologist. An ophthalmologist is a medical doctor, an MD. They've gone to medical school. They've done an internship and 3 years of ophthalmology residency. They have fully trained in eye surgery, and then they may have stopped there and gone into practice, or they may have subspecialized and be a cornea specialist, who I mentioned as the surface of the eye, and dry eye specialist. They may be a retina specialist. They may be a different kind of specialist for the eye. So that's an ophthalmologist. An optometrist has not gone to medical school. They've gone to optometry school, and they haven't studied all of medicine, but they've well studied the eye, and they sometimes in different states do certain procedures for the eye, and they are excellent at glasses. They excel at that more than anyone else does in terms of what glasses are going to serve you the best, and contact lenses. And so some people are followed by one or the other. So if you have started with an optometrist and maybe you're not getting what you need, then maybe see an ophthalmologist. If you saw an ophthalmologist, maybe see an optometrist and see if they can do something better with your glasses. So you can always try both of those. And if you're still not happy with your vision after both of those, then you would seek out a neuro-ophthalmologist. If dry eye is the problem, you would seek out a cornea specialist. Otherwise, a neuro-ophthalmologist. Now, you may have to travel. If you live in a small town, if you live in a rural area, there might not be a neuro-ophthalmologist right next door for you. So you may have to go to a big city, to a major academic medical center. But in most big cities in the United States, there are some neuro-ophthalmologists around and accessible in any given state. So that's the difference between the different kinds of eye doctors.
Great.
And then the question, there was a question that I sort of lost sight of there. If you could repeat that back to me.
So Fred had asked, he wasn't happy with his evaluation. What would be the next step? And I think you answered that. So thank you so much for that.
Thank you.
And Nancy asked a related question: how do you find a neuro-ophthalmologist? And I think you answered that as well. Do you have any more tips if you're looking specifically for a neuro-ophthalmologist? Is no one around you knows? Is there a directory? Is there some way to find one?
That's a great question. So you could always ask your eye doctor. They're going to be familiar with neuro-ophthalmology, and they might be able to direct you to someone that they send patients to. But if that is a dead end and you don't get a name that way, then we do have a national organization. It's called the North American Neuro-Ophthalmology Society. That's a bit of a mouthful. But if you look up things online, you do Google search or any kind of search engine, and you Google Neuro-Ophthalmology Society, that's what you're going to come to. We abbreviate it NANOS. And so on the NANOS website, there is a tab for patients, and in that tab is a Find a Neuro-Ophthalmologist option. So you can enter your location, and they will give you a list of the neuro-ophthalmologists who are nearest to you.
Great. That is extremely helpful. We had many people ask over the chat about whether their diagnosed eye problem was related to Parkinson's disease. And it would be hard to address each individual one, but let's pick a one, like nonarteritic anterior ischemic optic neuropathy. Would that be something that may or may not be related to Parkinson's, or may enhance an eye problem that Parkinson's has caused? How do eye problems that you've been diagnosed interact with an eye problem that Parkinson's may cause?
That's a great question. So you chose one that is in my subspecialty. So that's nonarteritic anterior ischemic optic neuropathy, just for example, but we could basically fill in the blank. Macular degeneration, cataract, retinal detachment, glaucoma. My answer applies to all of these eye diseases. They are not directly linked to Parkinson's disease. Parkinson's disease does not increase the risk for these problems, and they are just completely separate from the Parkinson's disease. Now, to answer the second part of the question is, can they impact vision in Parkinson's? Can they kind of compound the problem that a patient with Parkinson's is having? There's not a black and white, real straightforward way to answer that, but I would say that they could potentially, just because they could be another source of visual confusion. So if you're already kind of struggling with dry eyes from not blinking very much, and then you maybe have some convergence weakness on top of that, and you get another eye problem on top of that, just the more problems there are, the more challenging the vision becomes, and the more important having all the right eye specialists on board, because each should be doing the optimum that they can to address this situation that's present for their subspecialty. So some patients feel a little silly having 3 or 4 different types of eye doctors, but that's where the persistence part comes in as well, is you get what you need, and the eye's a complicated space and the brain's a complicated space, so you can have several eye doctors.
Fantastic. Thank you. So we have a great question, which is, are there eye surgeons who specialize in eye surgery for people who have tremor? So more generally, if you are somebody with tremor and you're getting a surgery like cataract surgery, what are things that people have to worry about, or any special things that are done?
Yeah. So I will preface the answer, any attempted answer that I give to this question, by stating that, as I said, I'm a neurology trained neuro-ophthalmologist, so I am not a surgeon. Not a day in my life. I have only been in an operating room as a medical student. So I think the surgeon knows the answers to these questions the best. So if they do things under general anesthesia, for example, then things like tremor or head movements are not going to be an issue. So there are definitely options that the surgeon has to deal with any of the other medical issues that a patient may have. And if that's tremor and there's concern for motion during surgery, they have the option of general anesthesia or other ways to make sure, always putting safety first. There's a lot of factors that go into those decisions. Now, the question was specifically, I think, about a surgeon for strabismus. Did I hear that correctly?
The surgery was for cataracts in the question.
For cataracts. Okay.
Yeah.
Yeah. So, your general ophthalmologist should be well familiar with operating on patients with different neurological conditions and medical conditions, and certainly should be prepared to have that conversation with you. But it shouldn't be an obstacle to you getting a successful surgery.
Thank you so much. A great question from Carol. What is the association between vision and driving? Do you think Carol will have to stop driving? How do you evaluate that?
Typically for Parkinson's disease, vision remains fine for driving. Vision is the least of my concerns with driving with Parkinson's disease, and the other concerns that I harbor about it, I defer to the movement disorders neurologist, because those would be things like, most highest on the list would be reaction times. Are you able to react fast enough if something comes up quickly? Convergence weakness should not be a hindrance to driving, because you're using distance vision for driving. And Parkinson's disease does not make you lose vision in an eye, and so therefore should not be something that really impedes your ability to safely drive from a visual standpoint.
Great. So we have a question, if you could just repeat the association for neuro-ophthalmology for Nancy. do that quickly.
Oh, sure. The North American Neuro-Ophthalmology Society, and we abbreviate it NANOS. So I suspect if you just Googled Nanos eye, you'd probably get there.
Great, thank you. So we amazingly have come to the end of our time. We have one more question that we can get in. And so I'd love this question to be about other Parkinsonisms. So not Parkinson's disease, but related disorders that may impact Parkinson eye movements more than Parkinson's does. We haven't really talked about that at all. Could you, anyone who is in our audience who may not have Parkinson's disease, but may have one of the related disorders and may have eye movement problems from that, or double vision from that, or other issues in their eye movements, would you be able to address what the possible treatments would be for those people out there?
Certainly. So I'll say one thing very briefly, which is that in other types of Parkinsonism, we use eye movements to help us with the diagnosis, but the specific question is the treatment. So the same issues of dry eyes and convergence insufficiency are very, very common in patients with other types of Parkinsonism. But there also can be some more double vision at distance. And so that's where things get a little tricky. The most common treatment would be the prism glasses, but they might need to be different prisms for walking around your distance glasses and then for reading. So you really need someone pretty skilled, a good neuro-ophthalmologist or really good optometrist to help you figure out what the prism needs are in your far away and your up close glasses, more so than with idiopathic Parkinson's disease.
Thank you so much. So I wanted to take this opportunity to thank Dr. Rucker for her presentation, for answering all those questions. I wanted to thank everybody in our audience for such an active, lively conversation and for giving us all your thoughts about vision. And obviously, it is a topic that affects people's quality of life quite significantly, and I'm glad that at least some of you were able to get your questions answered with Dr. Rucker. So thanks again, everybody. And I want you to be aware that if you know someone who missed today's program, if you joined late, if you'd like to watch this again, this recording will be available, or currently available already, on our YouTube channel. So when you're there, don't forget to subscribe to our YouTube channel, and you'll be able to watch this video again, as well as all of our other broadcasts and anything new that comes up. So for additional information and resources, please visit our website at apdaparkinson.org. And I also want to let you know that our next Dr. Gilbert host will be taking place on November 21st, this time at 5:30 p.m. Eastern Standard Time. We'll be discussing the dental challenges of people with Parkinson. So that's another topic that isn't talked about enough. So we hope to see you then in November. So be sure to stick around for a few final messages. And before I go, I want to thank you again for joining us and participating. And we hope to see you on another APDA program really soon. Have a great afternoon.
Hi, I'm Leslie Chambers, President and CEO of the American Parkinson Disease Association. Thank you so much for joining us today on our program. Every day, APDA is committed to providing helpful programs just like this one, as well as a wide variety of support groups, exercise classes, and educational programs to support the Parkinson's disease community. Whether online or in person, APDA is here for you every step of the way. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. We keep you posted on our social media channels as well, so make sure you follow us there. You can also connect to local resources and events through our nationwide network of chapters and information and referral centers. Remember, we're just a click or a phone call away. If you've enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Every gift, large or small, helps APDA support people living with PD through thoughtful programming, reliable resources, groundbreaking research, and more. Please visit apdaparkinson.org/donate today to support our critical work for those with Parkinson's. We are so grateful for your generosity. Thank you.